Drug allergy in pregnancy. Kelly, go ahead.
Okay, thank you so much, Len. As Len mentioned, I'm Kelly, for anyone I haven't met yet. Recently joined faculty at the University of Washington, and I am honored to be giving the first talk of the teaching series in 2025 this year. So thank you all so much for joining. Okay, so just to start with an outline in terms of what we'll be discussing this morning. So I first wanted to start with a big picture view of anaphylaxis during pregnancy, of which drug allergy is the most common cause. Next, I wanted to talk about some indications for medication use during pregnancy and what types of medications we might expect to see patients using. Um, Following that discussion, we'll talk about drug allergy in pregnancy. There is overwhelmingly the most evidence and information available about penicillin allergy. So we will spend a bulk of time just talking about some recent research and updates to that, followed by a discussion of anesthesia, NSAIDs and aspirin, latex, even though it's not technically a drug, and some miscellaneous interesting culprits of anaphylaxis during pregnancy. And then we'll follow that discussion by management of drug allergy and suggested treatment modalities. And then a quick slide about the drug allergy referral process here at UW from OBGYN. Our objectives this morning will be 1, to recognize the prevalence of drug allergy during pregnancy, 2, to understand the evaluation of drug allergy during pregnancy, and 3, to understand the management and treatment of drug allergy during pregnancy. I have no disclosures to report. Okay, so to start off, I wanted to have a brief discussion of anaphylaxis during pregnancy, which might present differently than we would expect for a non-pregnant individual. The prevalence of anaphylaxis during pregnancy is not super common, but still clearly occurs. So estimated to be about 1.5 to 3.8 per 100,000 pregnancies. Here in the US, it's estimated to be at the higher end of that number, around 3.8. Something important to note about anaphylaxis during pregnancy is that there can actually be a lack of cutaneous symptoms in up to 35% of cases. So it's important to know that we might be expecting to see a different set of symptoms when anaphylaxis presents during pregnancy. Some signs and symptoms that are unique to anaphylaxis during pregnancy can include things like low back pain, preterm delivery, fetal distress, uterine cramps, vulvar and vaginal itching. Some of these findings, like low back pain, might be normal findings anyway in pregnancy. So just important to keep in mind the context in which these are occurring. Hypotension is a relatively common presenting sign of anaphylaxis during pregnancy. And I did want to point out just a quick reminder of some of the normal hemodynamic changes during pregnancy. Systolic blood pressure typically does not change, but diastolic blood pressure can decrease by 15%. It's something normal that happens. There can also be significant supine hypotension that occurs typically in about 10% of pregnant individuals just because of obstruction from the inferior vena cava from the gravid uterus when somebody is laying down. And then just a couple of other points, heart rate can increase by up to 15% and respiratory rate can increase up to 10%. So just important to keep in mind in terms of the context and the situation in which these things are occurring. There, of course, can be many other causes of hypotension during labor and delivery. So just a reminder of a few of those. Things like spinal anesthesia, of course, general anesthesia if needed for something like a C-section, specific situations for C-sections. And then, of course, scarier, more insidious things like hemorrhage, placental abruption, etc. Okay. Just hope my camera is not blocking the slides for anybody here. I also wanted to mention a couple of interesting risk factors for anaphylaxis during pregnancy. One risk factor is that women with any type of allergic history had a four time higher odds of developing anaphylaxis. So this is a history of allergy to really anything else, a history of drug allergy, latex allergy, venom allergy, food allergy, etc. There was one review that found women to have about a 4 times higher odds of anaphylaxis if they had any history of those conditions. Non-weight race is also associated with a greater odds of anaphylaxis. This same study had found that the odds of anaphylaxis during a pregnancy-related hospitalization were 1.5 times higher for Black women and about 1.9 times higher for any women who reported non-white as their racial identity. There are a few thoughts as to why this might be. Unfortunately, oftentimes racial minorities are marginalized groups in healthcare and may lack insurance, causing them to present later to antenatal care. Because of this, things can be missed. Parts of the history certainly can be missed as the obstetricians are focusing on some of the more immediate issues in pregnancy. Pregnancy can also be the first time that women are in contact with the healthcare system, which is important to remember as well. So they themselves may not be aware of an allergic history. Another thought behind this statistic is that because of this delay in care and other risk factors, sometimes these women are more likely to undergo a C-section. And as we'll talk about, a C-section is absolutely a risk factor for anaphylaxis during pregnancy. So I'm going to talk a little bit more about that on the next slide. So this is a graphic pulled from that same study looking at anaphylaxis during C-section. So women who underwent a C-section were at had a 4 times greater odds of developing anaphylaxis during labor and delivery than women who did not. In the red line here, this is patients who underwent C-section and developed anaphylaxis, as opposed to patients who did not undergo C-section and developed anaphylaxis. In one systemic review and all the articles that they had looked at, they found that overall, in terms of anaphylaxis during any stage of pregnancy, 50 to 75% of those cases occurred during a C-section. So that's a really large chunk of the cases of anaphylaxis that can occur. Next, I wanted to break down anaphylaxis sort of by timing during pregnancy, because
Kelly, are you going to explain why that is?
Yes, we're going to explore some of the causes in upcoming slides, but a brief answer to that would be just exposure to many more things like instrumentation, in some cases, general anesthesia, latex, antibiotics, et cetera. But we'll talk a little bit more about that.
All right.
So anaphylaxis during pregnancy, again, looking at timing of anaphylaxis can be very helpful in identifying the culprit. During the first trimester, the causes of anaphylaxis are actually the same as non-pregnant individuals. So things like food, venom, medications, latex. The second trimester is when we start to see a shift towards things like antibiotics, latex, and anesthetics being the more common causes. A larger systemic review published a couple of years ago actually put an estimate on the frequency of the causes of these events during particular trimesters. And so in the third trimester, they had estimated antibiotics to be responsible for 58% of cases of anaphylaxis, latex to be responsible for about 43%, and anesthetics to be 14%. And then in terms of delivery, it really depended on what sort of delivery method a woman underwent. So for spontaneous vaginal delivery, again, this is a really small number of patients, but anesthetics were actually estimated to be the most common cause. We'll talk about this in a future slide. This is probably an overestimate, followed by antibiotics. And then for C-section, there was a tie between antibiotics and latex as the most common causes.
Kelly, do you know, I assume that latex has been replaced almost universally. So is this old information, or are there still places where there's no substitute for latex?
So we'll talk a little bit about that on a later slide, but there are still situations in which latex is used. And even though the overall prevalence of latex allergy has decreased, there is not currently information about those trends being reflected in pregnancy. So I don't have a number in terms of as a whole in the United States, like what percentage of healthcare systems are using latex versus non-latex, but there are still situations in which there is latex exposure. And so this does still pop up sometimes. In terms of medication use during pregnancy, super common for both prescription medications and over-the-counter medications. There were a few different studies that estimated anywhere from 60 to 90% of pregnant women use at least one medication during pregnancy, and we'll talk about some common reasons for that. Over-the-counter medication use is also extremely common, with some estimates that about 90% of women use something over-the-counter at some point during pregnancy. Of the medications, the prescription medications used during pregnancy, antibiotics are overwhelmingly the most common cause. Around 70% of pregnant women use an antibiotic at least once during pregnancy, and antibiotics account for almost 80% of all prescription medications used during pregnancy. Again, thinking about medication use in terms of timing during pregnancy can be helpful as well. So just a quick reminder of a few indications that might warrant treatment. During pregnancy, of course, things like asymptomatic bacteriuria, infections like syphilis, this would certainly warrant treatment. Another condition that we'll talk a little bit about, I guess, indirectly in a few slides, is preeclampsia. There are expanding guidelines from the obstetricians as to who qualifies for aspirin for treatment and prevention of preeclampsia. So this is something that we probably will be seeing more commonly as allergists in upcoming years. During delivery, group B strep is a very common reason why women might be treated with an antibiotic. Prior to screening for GBS, group B strep was one of the most common causes of neonatal death. And it's estimated that about 30% of women are colonized with group B strep. They're screened in the third trimester and have found to be positive, treated with the first-line antibiotic choice being a penicillin antibiotic. Some other reasons could be infections during that time frame of labor and delivery. So things like fever of unknown origin, premature rupture of membranes, chorioamnitis, or endometritis. Typically, cephalosporins are used as first line for a surgical site infection prophylaxis for C-sections. And as a reminder, C-sections account for about 30% of deliveries here in the US, so it's a pretty high number. And then things like pain relief, which we'll also discuss, where NSAIDs are typically the first line medication indicated. So that's an important one to remember. And then for postpartum, things like mastitis, any sort of C-section complications, and again, continued pain relief. So I did want to spend a portion of this presentation with just a refresher about penicillin allergy during pregnancy, and some of the newer research about this topic. Similar to the non-pregnant population, 1 in 10 women report a penicillin allergy, but upon actual testing, over 90% of these women do not actually have a penicillin allergy. Beta-lactams are extremely common to prescribe during pregnancy, as we had discussed during the last slide. So indications like a positive group B strep, C-section, syphilis, etc. Again, similar to the non-pregnant population, there are a number of adverse effects, and this has been studied specifically within the context of pregnancy. So increasing use of broad-spectrum antibiotics, which maybe are not as helpful for treating that specific infection, an overall higher cost of care. And then also adverse effects like new drug adverse reactions and longer hospitalizations have also been reported. This graphic here is taken from a review by Dr. Kim Blumenthal and her colleagues from 2020, and I thought it was just a helpful way to sort of visualize some of the things we're going to talk about. And it's also a helpful review for non-allergy providers. It's a pretty straightforward read and has a lot of great graphics. So just as a reminder of the risk stratification, specifically within the context of pregnancy. So low risk symptoms are included to be things like headache, nausea, vomiting, itching. And in these situations, penicillin can just be tried again when indicated. The authors consider moderate risk to be a history of rash, specifically urticarial rash or hives. For this situation, they recommend that skin testing is done in the third trimester. We will talk more about this as well, but this, increasing evidence is demonstrating this doesn't necessarily need to be in the third trimester, that the second trimester could be an option as well. And then with a negative result, a direct oral challenge. And again, we'll discuss some of the emerging data about skin prick testing versus direct oral challenge in pregnancy. For severe reactions, which are considered to be anaphylaxis and severe cutaneous adverse reactions, they do not recommend testing during pregnancy. For anaphylaxis, I think depending on the indication, there can be a case-by-case discussion, but it's pretty universally agreed that for a history of SCAR, there's no proceeding. So I also wanted to quickly review this graphic that is actually taken from some of the obstetric literature. This is from a 2020 update on the committee opinion from the American College of Obstetrics and Gynecology about the prevention of Group B strep in newborns. And I just wanted to point this out because there's a couple of differences as compared to the allergy literature. So they have their own risk stratification system here, but it's not a risk stratification system in terms of how to risk stratify people for testing. This is more in terms of how to proceed with management of Group B strep. So they consider low risk patients to be people that essentially don't have symptoms consistent with an IgE mediated hypersensitivity. So things like GI distress, headaches, like a yeast infection, a non-urticarial rash, itching without a rash, family history, etc. They consider a high risk reaction to even be any sort of urticarial rash, immediate flushing, angioedema, etc. Essentially anything suggestive of anaphylaxis. And then they also consider any sort of severe cutaneous delayed reaction to be high risk. You'll note here that they don't have a medium risk category. Essentially, these categories exist for obstetricians to decide how to next treat patients in the third trimester. So if there is any history of penicillin allergy, it's recommended that clindamycin sensitivities are added to the swab. And those individuals who are low risk are recommended to actually receive a cephalosporin in place of a penicillin. And then individuals who are high risk and clindamycin sensitive receive clindamycin, and individuals who are high risk and not sensitive to clindamycin receive vancomycin. So again, a suboptimal treatment for Group B strep. But they do recommend pretty explicitly in their guidelines that these patients are recommended to be evaluated by an allergist and to have testing during their pregnancy. So I point this out just to highlight that this is something very much on their radar as well. Okay, so next I wanted to review a couple of more recent studies that exist about really looking at the safety profile of penicillin allergy testing during pregnancy, and just wanted to point out a couple of interesting highlights from these more recent articles. In this first article here by Kudar and colleagues, we see it's a pretty small N. Only 46 patients underwent skin prick testing, 2 of which had a positive test. Interestingly, only 18 of those patients of the 44 that passed opted to undergo an oral challenge, but all of those patients passed. In this study, the average gestational time was actually 25.8 weeks. So most of these were done during the second trimester. And there were no major adverse reactions noted. So no cases of anaphylaxis reported for mom, no sort of adverse fetal effects, etc. So this had a great safety profile. In this next study here by Wolfson and colleagues, we see a larger N. There were 220 skin prick tests done. I did want to point out they were doing a retrospective chart review. Overall, there were 389 obstetrician ordered e-consults, and they had recommended an in-person evaluation for 363 of these. So ultimately, less than 60% of patients that were referred actually were able to attend an allergy appointment or opted to attend an allergy appointment. Of those individuals, 3 had a positive skin prick test. And then 210 of 213 patients underwent an oral challenge with 210 patients passing. So about 98% of patients did pass. Of the patients that did not pass, there was 1 patient that developed a non-urticarial rash within an hour that was treated with oral antihistamines, and then 2 patients with a delayed reaction that was benign and treated symptomatically, and no major adverse outcomes were reported. In this study, all the patients were in their third trimester. This next one here, there were 46 skin prick tests done. This study specifically recruited low and moderate risk patients. Interestingly, they also made a point of mentioning that only about 58% of eligible patients who were referred were actually enrolled. They actually had looked at the reasons for why people that were not evaluated declined to be evaluated, and found that the most common reasons were time constraints and concern for fetal well-being. only one skin prick test was positive, and 43 of 45 people passed the oral challenge. Interestingly, the 2 people that failed had a low risk history of a benign cutaneous rash greater than 10 years ago, but had actually developed symptoms concerning for anaphylaxis after the oral challenge, both of which were treated with epinephrine. Despite this, there were no major adverse effects for mom or baby. There were no adverse fetal outcomes. Both mothers who had to receive epinephrine were not hospitalized. So despite a more severe reaction, there were no major adverse outcomes to report. Half of these patients were in their second trimester for the study, and the other half were in their third trimester, and they didn't note any sort of difference in outcomes between trimesters in terms of passing the test or safety profile. This next study here by Patel and colleagues, 133 women underwent skin prick testing, only 2 had a positive test. 100%, so all 131 women that were challenged did pass. And there was kind of a spread of where women were in their pregnancies. There were actually 2 in the first trimester, and it wasn't clear from the review if the authors were aware at the time of testing that women were pregnant, as testing is generally not done in the first trimester. But the other split of the patients were essentially both second and third trimester, and again, no sort of difference in outcomes noticed based on timing. These authors also emphasized that patients that underwent penicillin allergy testing, as opposed to women who did not, had no sort of major adverse outcomes associated with their pregnancies. They didn't have a higher rate of C-sections. They didn't have any additional pregnancy complications. So just thinking back to the concern one of the other studies had demonstrated with concern for fetal well-being, this study had a really great safety profile of women who did undergo testing. They also found that of the group that underwent testing, about half of these women who did end up needing beta-lactam antibiotics during the intrapartum period for various reasons. All but one tolerated the beta-lactams, and that one who did not, it was more of subjective symptoms. There were no objective findings or hemodynamic changes. And then this last study here, something I wanted to highlight was they actually had, this was again a retrospective chart review. There were 689 women who had a documented penicillin allergy. 232 of those women were actually referred. So just about 30% of those women were actually referred from obstetrics to allergy. And only about half of them, 117, underwent testing. So a fraction of the women really who were eligible. Only one of those tests were positive, and everybody passed the oral challenge. So again, fantastic safety profile, and most of these patients were in their third trimester. So to summarize, I just wanted to emphasize a few take-home points from this slide. One is that the evidence overwhelmingly shows that penicillin allergy testing is safe to perform during pregnancy. We can see from these numbers that, by far and wide, women are passing these challenges, and that there were no major adverse outcomes reported in any of these studies. Something else I wanted to highlight that is something that I'm exploring here at UW is the proportion of patients that are actually referred and seen seems to be quite small as compared to the patients that are overall eligible for testing and evaluation. And so something I'm personally interested in is exploring these barriers of what the disconnect seems to be in terms of getting patients referred and actually getting these patients seen and tested in our clinics.
Kelly, you made the comment that most testing is not done in the first trimester. I mean, maybe you could argue it should be done in the first trimester so that later in pregnancy, when you have to make a treatment decision, you already know the answer, as opposed to having to do it on the spot when the issue comes up in the third trimester.
Yeah. I think that is certainly a valid argument. I think the other side of that is just that the first trimester in general, irrespective of allergies, can already be such a high risk time. And there's already a pretty high rate of miscarriages, like unrelated to any sort of testing. And so the thought is just to wait for things to settle until patients are a little bit further in their pregnancy. But I think that argument is very valid in terms of thinking about testing in the second trimester, before women are even screened for group B strep. And, having this time frame that's a little bit less chaotic, as opposed to like so many things can happen at the end, having this to be something evaluated before a lot of that chaos ensues.
The other question I would have is the few patients who were test positive, when you went back and looked at their history, did they have more severe histories, more consistent with a true IgE reaction?
Yeah, that's a great question. From what I had reviewed, and most of these had a table in terms of the patient profiles of who tested positive versus negative. And interestingly, there didn't, so all of those studies reviewed, nobody tested high risk patients. So nobody tested patients with a history of anaphylaxis. These were for low and moderate risk patients. So starting out, the risk was already relatively low. But most of the patients who tested positive actually did have a lower risk history of like a benign cutaneous reaction, typically greater than 5 years ago. So it was interesting there. From what I saw, there weren't any trends in terms of this being like a more recent reaction or a more severe reaction at baseline, predisposing these women to test positive.
Lily put in the chat, I suspect some of the skin tests were false positives, but
Yeah.
unless you challenge them, you don't know.
Yeah, exactly. And I think, again, this gets into sort of a gray area in pregnancy where it's when, we're in general more risk adverse, as opposed to a non-pregnant patient where we might just proceed anyway. So I think, again, this is sort of a case by case decision. But again, from what I saw in those reviews, none of the patients that had a positive skin prick test actually opted to undergo direct oral challenge. So we don't know for sure if those skin prick tests were true positives. One other point I wanted to touch on was the idea of penicillin skin testing versus oral challenge. I'm sure as many people on the call are familiar with, in our most recent drug allergy practice parameters for non-pregnant patients, there's been an increasing shift towards proceeding directly to oral challenge for patients with a low risk history of penicillin allergy. So patients that have things like a benign cutaneous reaction greater than 5 years ago. Oftentimes we just proceed directly to an oral challenge. Whereas thinking back to the slide by Dr. Kim Blumenthal and colleagues, typically in pregnancy, the full testing has been done. So skin prick, intradermal, oral challenge, irrespective, even for the moderate risk histories of only like an urticarial rash, irrespective of timing. So this is something that has been more recently studied, although these studies have pretty small numbers, but I did just want to mention this because I found this to be an interesting shift. In one of these studies, these authors had actually randomized low-risk patients. They considered low risk to be a benign cutaneous rash greater than 5 years ago into penicillin skin testing versus a two-step direct oral challenge. And again, very small numbers, but they found that 20 or 91% of patients who underwent penicillin skin testing were negative, and 100% or all 16 patients that underwent a direct oral challenge were negative. They also pointed out a financial difference between these two testing modalities of about $150. So it's about $300 for somebody to undergo the full skin prick intradermal oral challenge versus about $150 to undergo a direct oral challenge. This other study here, they had actually classified women into low risk, medium risk, and high risk categories based on the PenFast clinical decision-making tool. This is an algorithm that can be used to stratify risk of penicillin allergy based on history. And so they sent all of the women who classified as low risk to a direct oral challenge. And they found that actually 203 of the 207 women that underwent direct oral challenge passed. The 4 patients that did not pass had a benign maculopapular rash that was treated symptomatically. And again, no major adverse outcomes were reported. So I thought that this was an interesting shift from how things have been done historically, and I think makes a lot of sense, especially when compared to how we treat non-pregnant patients, that for patients with a pretty low risk or benign history, considering going directly to an oral challenge is that the data that we have so far supports that this is a safe option and an effective option for patients. So in regards to non-penicillin antibiotics during pregnancy, unfortunately, there is a complete lack of data and information about this. It was really difficult to I even struggled to find case reports about any sort of like off-label testing that had been done for non-penicillin antibiotics during pregnancy. So there's really just no studies or protocols about how to proceed in these situations. I think just a few basic principles considering the need, the necessity of the medication, as compared to the risk profile of the patient. Is this something that we're even able to test? And then just as a reminder, knowing what medications are able to be used during pregnancy and what medications are contraindicated is important too. And I have a slide at the end of this presentation reviewing some helpful resources, since this is not something that as allergists we're really encountering on a day-to-day basis. So next I wanted to briefly discuss anesthesia allergy during pregnancy, because this was one of the more common culprits during the later stages of pregnancy and delivery. So just as a reminder, again, thinking back to that earlier slide, the risk of, or the incidence of anesthesia allergy really depends on delivery method. So for cesarean sections under local anesthesia, antibiotics and latex tied is the most common causes. There were very, very few reports of any sort of concern for allergy to local anesthesia. For C-section deliveries under general anesthesia, muscle relaxants were reported to be the most common cause. Again, this is a really small number of cases. There's not very many cases that are done under general anesthesia. These tend to be higher risk cases to begin with. But for the cases that were reported, succinylcholine was the more common culprit. And in these cases, these were unfortunately similar to non-pregnant perioperative cases, more severe cases of anaphylaxis. So there were no cutaneous symptoms in the 3 cases reported. And there were severe cardiovascular signs associated with bronchospasm for these individuals. So these were unfortunately on the severe end of the spectrum. This I thought was particularly interesting, thinking back to the earlier slide where for spontaneous vaginal delivery, local anesthesia was reported to be a more common cause of anaphylaxis. The authors do acknowledge that this is probably a pretty large overestimate. One reason being that this is such a small number of patients to begin with, and many of these were not validated allergies. This was suspected based on timing, and not all of these were like skin test proven. In patients who are not pregnant, there is emerging data that actually the true prevalence of aminoamide anesthesia allergy is probably less than 1%. So this is probably an overestimate, especially as we're looking at other procedures where this is just not very commonly reported. And so something important to keep in mind, but I think as we continue to gather evidence, this is probably not something that is a true IgE-mediated allergy. But something to be on our radar nonetheless.
Well, Kelly, I've always thought that the actual percentage of people with local anesthetic allergy is 0.
Yeah.
So does it sound like there are any cases that truly sound like true IgE mediated disease?
Yeah, there are a couple of case reports where based on both presented symptoms at the time and timing based on exposure, and then followed by, again, skin prick testing, intradermal testing, that these patients were found to be positive. So it is suspected that there are maybe some cases of true IgE-mediated hypersensitivity, but again, even with the testing for that, it's not something that is validated like penicillin testing. And so I think we do have to take those findings with a grain of salt. I next wanted to address NSAID and aspirin hypersensitivity in pregnancy. This is not one of the most common causes of anaphylaxis during pregnancy, but I do think that this is going to be something that we're encountering more and more as allergists. Aspirin is recommended to reduce the risk of preeclampsia for pregnant patients with certain risk factors. And in recent years, these guidelines have been even further expanded as to who meets criteria to take aspirin during pregnancy. And so there's many, many risk factors listed, but just a couple to mention are things like BMI, advanced maternal age as a consideration, a nulliparous pregnancy, a family history of preeclampsia. So there's actually really quite a few reasons why a woman might be recommended to take aspirin during pregnancy after the 12th week. And it sounds in the OB literature that this is going to potentially expand even further in future years to include low-risk patients. So I think something really important for us to be aware of. About 2% of women report allergies to aspirin or NSAID. So not a huge number, but certainly not insignificant. We fortunately have an expert among us at UW on NSAID hypersensitivity who has published a couple of these studies. So Dr. Lily Lee knows much more about this than I, but I just wanted to discuss a couple of important findings about NSAID hypersensitivity. So one study that Dr. Lee was involved with was really just showing that having the label of an NSAID allergy on one's medical record is not a benign thing to have. So they found that patients with reported NSAID adverse drug reactions had higher postpartum inpatient opioid use and were more likely to receive an opioid prescription at discharge. And so this is again something that we really should be reviewing and considering as women are undergoing evaluation prior to delivery. In another study, so this was a case series that Lily had written as well, looking at it was a review looking at patients who were referred to Allergy at a large academic center in the last couple of years who had reported NSAID or aspirin hypersensitivity. There were 7 patients included in this. 5 of these patients had a history of acute symptoms after taking aspirin or NSAID. They were not AERD. 4 of the 5 had been evaluated in a medical facility but not received epinephrine. And then 2 of the 7 were just told to avoid aspirin or NSAIDs because of a history of chronic spontaneous urticaria. So for these patients, they actually had opted to undergo a direct oral challenge as opposed to desensitization, given the relatively mild symptom history. So 6 of these patients ended up actually being challenged. 5 of the patients were able to tolerate low-dose aspirin without an issue. I believe it was 3 of the patients had been directly challenged with 81 milligrams. And then 2 of the patients had more of an incremental increase, like a 2-step challenge. And the urticaria patients were told at home to increase their dose slowly over a series of days. One of these patients had developed angioedema at 60 minutes after receiving aspirin and had opted to not proceed. But the rest of the patients were able to tolerate aspirin without issue during their pregnancies. So I wanted to mention this because I think this is an important shift in terms of how we're thinking about management, whereas historically the advice may have been to either avoid or undergo a desensitization. As we know, desensitizations are both costly and time intensive for both the allergist and the patient. If there is a severe reaction history, desensitizations can be performed and have been reported in the literature. But again, for patients with more of a lower moderate risk history, the idea of a supervised challenge is could be a great option for some of these patients. Okay, and then I also wanted to briefly address latex allergy, even though this is not a drug allergy. Technically, this is one of the more common culprits of anaphylaxis during pregnancy. This is just more of a review, but latex allergy is a risk factor for anaphylaxis during pregnancy. And as I had mentioned previously, while the overall prevalence of latex allergy is decreased because latex products have been increasingly replaced by non-latex products, we're not really sure how that shakes out in pregnancy. There's currently not any recent data available about the trends of latex allergy during pregnancy and if those have concurrently decreased with the general population. Pregnancy itself is not thought to be a risk factor for latex allergy, but there is a little bit of a caveat. Having patients who have undergone multiple surgical procedures are at higher risk for a latex allergy. And so for patients who have undergone have had multiple pregnancies in the past that have been C-sections, there is some evidence to suggest that those patients may be at a slightly increased risk, particularly if latex products had been used. And then this little graphic here to the right is just a reminder in terms of increased risk for latex allergy in all patients, not just pregnant patients. So people that have had a history of things like spina bifida and congenital genitourinary abnormalities, people that are exposed frequently, like healthcare workers, people working in the rubber industry, et cetera, people with other atopic conditions, and then people that have undergone multiple surgical procedures. And then I just wanted to put a reminder in here as well that type 4 hypersensitivities can also occur. This is thought to be due to chemicals mixed with the latex proteins, such as thiourams, mercaptobenzethiols, and thiocarbonates that can cause a type 4 hypersensitivity reaction. And this is something that can be assessed by patch testing following pregnancy. Lastly, I just wanted to touch on a couple of interesting miscellaneous drug allergies during pregnancy that I thought were really interesting. One of which is synthetic oxytocin, best known as Pitocin here in the US. This is something that is often used to augment labor as part of an induction or otherwise. There have been a handful of case reports of suspected IgE-mediated allergies to synthetic oxytocin with subsequent testing. One part of the literature that I thought was particularly interesting is that there is a thought that there may be a cross-reactivity between some of the proteins in latex and some of the proteins in oxytocin. So specifically HEV-B 7.01 and HEV-B 7.02 in latex in at least in ex vivo in a lab study that there was shown to be cross-reactivity. And in the handful of case reports of suspected allergy to synthetic oxytocin, several of these individuals were also allergic to latex. It's also possible that there has been a case reported of allergy to preservatives contained within synthetic oxytocin, as opposed to the active ingredient or the oxytocin itself. Oh, I was just searching for the name of what it was, and chlorambutal was the culprit of the preservative that had caused this allergy, and was actually, this person was later skin prick tested and found to be positive to the chlorambutal. Synthetic skin prick testing has also been done for synthetic oxytocin. So again, not something that there's a ton of data on, but there are case reports describing like the concentrations used and how the testing was performed. Something else I wanted to point out, just thinking back to an earlier slide where we discussed that hypotension can often be a presenting sign of anaphylaxis. One of the expected physiologic effects of oxytocin can be a decrease in blood pressure. So this can be something normal that happens after administration of oxytocin. There can also be vasodilation as part of the normal effect of oxytocin. So just important to keep in mind in terms of differentiating like the normal effects versus an allergic reaction. Another interesting one that I think is probably not super relevant here, but is something called laminaria, which is a sterilized dried seaweed stick that I don't think is typically used in the United States, but has been used in other settings to dilate the cervix and induce labor. There have been 2 case reports of individuals with a suspected IgE-mediated allergy, followed by testing, who were positive. So just a weird one to keep in mind. And then some of these others are, things that we would think of in non-pregnant individuals as well, but just important to remember, as many things can happen and there can be many different medication indications during labor and delivery. So things like blood products, proton pump inhibitors, IV iron, and chlorhexidine were some of the other culprits. In regards to anaphylaxis management during pregnancy, so unfortunately, the only systemic review that currently exists on anaphylaxis during pregnancy, they found that only 17% of agents were able to be identified when allergy testing was pursued after pregnancy in terms of finding the culprit of anaphylaxis for that event during pregnancy. A part of why this number is so low is that there, again, seems to be a big disconnect between referral and follow-up, which is understandable during this chaotic time period, but again, is important, especially if a woman is planning on subsequent pregnancies, to try our best to identify what the trigger may have been. In this systemic review of anaphylaxis during pregnancy, about 75% of the articles had recommended treating anaphylaxis essentially the exact same way that we would treat a non-pregnant patient. The other 25% of articles that did not explicitly make that recommendation had just not mentioned their recommendation for management. So it wasn't that there was like a different approach. But essentially, for any case of suspected anaphylaxis, prompt administration of IM epi at the same dose as a non-pregnant patient is critical. Things like albuterol if there's bronchospasm, supportive measures at the discretion of the obstetrician delivery. And then obtaining a serum tryptase has been found, similar to non-pregnant patients, to be a helpful decision-making tool as well. I did want to point out that specifically within the context of labor and delivery, another cause of elevated tryptase was found to be an amniotic fluid embolus. The pathophysiology of this is not completely understood, but it's thought that there's some sort of mast cell degranulation involved in that. And so serum tryptase can be elevated in those situations as well. And there can be similar presenting signs and symptoms like flushing, hypotension, sudden hemodynamic changes. So just something to consider as well that I thought was interesting. Okay, I did just want to have a very brief slide reviewing the safety of allergy medications during pregnancy. Some of this is taken from the presentation I gave last year on general allergy management during pregnancy, but essentially to summarize, both first and second generation antihistamines are overall safe for use during pregnancy from the available data. I will point out just for fexofenadine or for Allegra, most human studies have not found there to be any sort of associated risk with birth defect. But if you look on UpToDate under the pregnancy section, they recommend other second generation antihistamines before Allegra during pregnancy, because there was one rat study where they had given them like much higher doses of Allegra than we would in people, and there were some fetal abnormalities seen, but this hasn't seemed to be the case in the human data that we have available so far. In terms of epi use during pregnancy, so I think this is something really important to counsel patients about that are going to be undergoing any form of testing or have an existing allergy. Epinephrine does cross the placenta, so that is something to be aware of. Some of the effects of epinephrine can be to decrease placental blood flow due to vasoconstrictive effects, fetal tachycardia. There's a possibility of preterm labor, although this is not something that's been like clearly borne out in the literature, but I think something important to mention as well. In terms of any sort of birth defect with epinephrine use, this is something that is obviously very difficult to study. Most of the literature we have is from animal studies. And so there, in one animal study where they were giving rodents like extremely high doses of epinephrine regularly on specific days of early organogenesis, they did find some teratogenic effects like gastroschisis. But again, this was like very high doses given repeatedly. And that's not so much what we would expect in like a real world scenario. With this said, I think important to share this information with patients. However, obviously anaphylaxis is life-threatening to both the mother and the baby. So overwhelmingly, typically the use of epinephrine outweighs the risk of anaphylaxis. So just wanted to put that in there as well. I'll just spend a couple of seconds on this slide here. These are just some resources that as clinicians that we can use, especially in not regularly managing pregnant patients in terms of medication safety profile. So Mother to Baby is a great group out of UCSD. They will have patients for free meet with experts if they have like individual questions on medication counseling. And they also have a very user-friendly website where essentially any medication can be looked up and it summarizes sort of the work that's been done in very patient-friendly language. For healthcare workers, this app, Infant Risk HCP, I've personally found this to be a helpful app to use. They summarize the animal and human data available for both pregnancy and lactation. And then I think most of us are aware that on UpToDate as well, there's a special consideration section for pregnancy and lactation that can be a quick, helpful way to look something up. Okay, I lastly just wanted to spend a couple of minutes on something I'm working on here at UW and to get any thoughts from the group if anybody has them. As I had mentioned during the slide reviewing the penicillin allergy delabeling studies, there seems to be a big disconnect in terms of how many pregnant patients with a drug allergy are actually referred, and then how many of those patients are actually seen by an allergy specialist. I worked with one of the EPIC specialists to extract this data. We were looking at the number of referrals from OB to allergy at UW in the last 2 years. There were actually only 44 referrals total between inpatient consults and outpatient, and 10 of those were drug allergy. So we're still going through the data in terms of what the drug allergy listed was. Were these patients actually seen and evaluated? What were the testing results? So that information I don't have just yet. But I did find it was striking that there have only been 10 drug allergy referrals in the last 2 years, when we know that the reported prevalence of penicillin allergy is relatively high. So I would love to hear any, I'm working with the OB group right now in terms of how we can address find out what some of the barriers might be for the obstetricians, and then what some of the barriers might be for patients to actually undergo testing, and then working together to optimize this referral pathway to get patients in more quickly, since this can be somewhat of a time-sensitive question. But would love to hear any thoughts from the group or from any of the community allergists that might be receiving OB referrals as well. I know some systems have an e-consult system where automatically a consult is placed for patients with a history of something like a penicillin allergy, which is not currently the case at UW. So we're just brainstorming different strategies to be able to prioritize these patients and ensure that they're evaluated. Okay, and with that, the word of the day is safety. And I'd be happy to take any questions at this time.
Kelly, I have a question about the safety of the second generation antihistamines back to that slide.
Yeah.
I don't remember clearly, but I didn't think all of the second generations were listed as safe during pregnancy. Although, if I read this correctly, the data would suggest they are all safe.
Yeah, there is no, for at least these like main ones that are typically used, Claritin, cetirizine, levocetirizine, and fexofenadine. The data has been reassuring thus far, with the exception of that one animal study for Allegra. But there's been no major, this is primarily in regards to thinking of birth defects, and there's been no major associations. Of course, this is something that's really difficult to study, so it's hard to say any of this is like, we don't know with 100% certainty that this is the case. But in terms of looking at these major epidemiologic and cohort studies, there hasn't been any data thus far to suggest that any of these second generations, with the exception of that one study with Allegra, are unsafe for use. There is, during breastfeeding, sometimes a concern that using antihistamines early in breastfeeding may affect supply. But again, I think that's sort of a case-by-case decision, and oftentimes patients with conditions like chronic urticaria opt to keep using them.
Kelly, I just asked the question in the
sorry,
chat, but
Oh,
Go ahead.
sorry, chat.
I just asked the question in the chat, but do the wait, I guess I'm from the OB side, are they concerned that there's like a long wait time, or like they wouldn't get someone in within their third trimester for testing?
Yeah, that's a great question. I don't know what the concerns are. We're actually working on, we should hopefully in the next couple of weeks have a survey for the OB folks designed where, it essentially is exploring barriers for referral. In speaking with one of the obstetric providers, it didn't sound like that was a major concern for them, that the patients, like they knew if they placed a referral, the patient wasn't actually going to be seen. So I don't know what exactly the disconnect might be, if it's maybe like logistically challenging for them to place the referral order on their end, or if there's just some sort of backlog, or if this is something that's really difficult to address with all the other things that they have to address in an appointment. But that's something that we're trying to gather some more data on so that we can figure out how to best expedite this process.
I have a question unrelated to your presentation. It had to do with sending out the invitation. I have a feeling that the invitation was not sent out as widely as it usually is for this session. So I'm just wondering if anybody who's listening signed on just because they knew from historical reference or being a member of the teaching series, they knew to sign on even though they didn't get an invitation yesterday. If anybody is in that situation, just let me know. I'm just trying to confirm if there's some kind of a snafu in the AID office about there's a new person there sending out the invite. Kelly, anything else?
No, that is all I have. Thank you all so much for joining so early.
Any other questions?
I don't have a question, but just a comment, Kelly. This is Patricia. I wonder in terms of because you're right, there's a lot going on for the OBs so early in the pregnancy. I wonder if there's a way in Epic to make it more systematic, just like our immunodeficiency kids that have radiosensitivity, where a flag comes up or it prompts an order for a referral, whether it can be incorporated into their order sets that have, in terms of their first trimester order sets, just so there's time for the referral to be processed, or if something can sort of automatically come up if there's both penicillin allergy and pregnancy.
Yeah, that's a great idea. To my knowledge, I don't know of like that being part of any specific order set. My understanding is that if that is something listed, the OB would need to kind of like go out of their way to address that and then subsequently place the referral, as opposed to other systems where there are automatic e-consults placed for anyone with like a listed penicillin allergy. Then there's an allergist who reviews them and deems like what needs to be seen in person or not. I think with, part of what we're hoping with this survey is that we can explore the OB's ideas on this, because I know sometimes there's like click fatigue with too many pop-ups. And so it would be great if we could find a way where this is something that's very low energy for, or like low effort for them, where they don't have to spend, a lot of additional minutes doing this. This is something that can just be, somewhat automated for the appropriate situation. I think adding it to an order set is a great thought. So TBD in terms of what we might do to improve this, but that's a great idea.
Thanks, Kelly. Good talk.
Thanks.
Okay, thank you again. Next week also will be virtual. DeLauer is going to be presenting.